guided tissue regeneration. Okay, myself, Dr. Jerry, I've been teaching in focus from the time we have started this institute, and right now I'm based in a small island known as Seychelles. It's in Indian Ocean. I've finished my MDS from Government Dental Calicut. Okay, in periodontics. Okay, so the topic that we are gonna see today is guided tissue regeneration. Okay, so before even we move into guided tissue regeneration, first I would like all of you to know what is periodontal disease. Okay, what is periodontal disease? Just a minute. My screen. Okay, so we are gonna first see what is periodontal disease. Okay, so can anyone tell me? You can send me a message. All of you can send a message saying, what can you give me the two main types of periodontal disease that we commonly come across? Two main types of periodontal disease that we commonly come across. Very common in your clinics that we see. Two types. Two major types of periodontal disease. Periodontal disease. Okay. Pocket is a what do you say is a consequence of that condition. Pocket is a consequence of something. Okay, again, somebody is saying generalized, localized. These are all, if you want to broadly classify, okay, now some of you are saying, very good, Sabit Lijas, very good. Somebody has put forward gingivitis and periodontitis. That is correct. If you want to simply explain somebody what is periodontal disease, it is two types of lesions that you have. Okay, what is that? Gingivitis and periodontitis. Now, what do you mean by gingivitis and periodontitis? Gingivitis is nothing but just the inflammation of your gingiva, just the inflammation of your gingiva. Okay, so here on this side, you can see a healthy gingiva, and on this side, you can see an unhealthy gingiva. Okay, now what is the difference between gingivitis and periodontitis? Can anybody tell me what is the difference between gingivitis and periodontitis? From both have itis. Both have itis. Itis meaning inflammation. Gingivitis, gingivitis. Periodontal itis, periodontitis. So what is the difference between both? What is the difference between gingivitis or periodontitis? Basic difference. Again, you can send me message. I can. Okay, very good. Sabit again is saying it is there is bone destruction. Where there is bone destruction, there is bone destruction in periodontitis. So what somebody said, there is bone destruction. So that is one feature that separates periodontitis from gingivitis. So in simple term, if I want to say, if the inflammation is just pertaining to your gums, in simple terms, if the inflammation is just pertaining to your gums, it is known as gingivitis. Inflammation of gingiva, gingivitis. Very simple. It does not progress beyond that. At that point where the inflammation is contained within the gingiva, here contained within the gingiva, then you call it as gingivitis. Whereas if the infection progresses and moves down into your periodontal ligament, into your alveolar bone, and onto your cementum, that means these are all different periodontal structures. If it progresses, if the inflammation progresses into these structures and there is damage of these structures, then you call it as periodontitis. I hope the basic difference is clear. Gingiva, just inflammation of gingiva. Whereas periodontitis, your other periodontal structures are involved, like your cementum, periodontal ligament, and your alveolar bone. Okay, so that is a basic gist of what your periodontal disease is. So you have periodontitis and you have gingivitis. Okay, now moving on to the next slide. Sorry. Okay, so now before even we go into these definitions, so once these conditions come, once you have gingivitis and periodontitis, there is destruction of the tissue there. Especially when it is periodontitis, there is destruction of bone, destruction of periodontal ligament, and destruction of your cementum. Now, what do you do? What is a common treatment that you do for all these kind of periodontal diseases? Let's talk about periodontitis now. When there is destruction of your cementum, alveolar bone, and your periodontal ligament, what is the treatment options that you give? What is the treatment options that you give when you have periodontitis? What do you do? As a simple clinician, don't think as a periodontist. As a dentist, what would you do? As a dentist, what would you do if a patient with periodontitis come to you? What is a basic treatment that you would give them? Basic treatment that you would give them before you refer the patient to a specialist. Okay, I'm waiting for your reply. Yes, scaling and root planing. Very good. So all of you are saying you're going to do scaling and root planing. Now my question is, why are you doing scaling and root planing? Why are you doing scaling and root planing? Why do you want to do scaling and root planing? Anybody? Why do you want to do scaling and root planing? Remove calculus. Somebody said remove plaque. Okay, now we studied periodontitis is inflammation within the periodontal structures that is causing destruction to the tissues. How is this destruction occurring? How is this destruction occurring? This is occurring by the accumulation of bacteria within these structures. Accumulation of bacteria within these structures, and these bacteria, what do? They will stimulate your cells in your body to release certain kind of agents that will cause destruction to your tissues. Okay, so let me just go back. So here we were talking about, so this is where all the plaque and calculus is. Now this plaque and calculus, what is a function? What is a function of calculus? Calculus, if it is there, it will help in retaining the plaque around it. That is a function of calculus. As such, it will not cause any damage to us. It is not causing any damage to us because it is a calcified structure. It will not have any bacteria which will cause damage to us. But what does this calculus do? The calculus will aid in accumulation of the plaque. It will aid in accumulation of plaque around it. Now, what does this plaque contain? The plaque contains proper structured different types of bacteria. Lots of bacteria inside the plaque. Now, this bacteria will release certain enzymes on of its own, and it will cause our host cells to release certain enzymes or certain factors. And together, they cause destruction of your periodontal tissues. Together, they cause destruction of your periodontal tissues. Now, as basic treatment, what we do, our aim is to stop that destruction. Okay, in what is the first treatment that we do is to at least stop the progress of the lesion. We want the lesion to at least stop progressing. We don't want it to cause more destruction to the tissue, more damage to the bone, more damage to the cementum. No, we don't want that. We want it to stop. How do we stop that? So we remove the causative agent. And now we know causative agent is your plaque. We know that the causative agent is your plaque. How do you remove plaque? By scaling. Okay, by doing supragingival scaling and subgingival scaling. Okay, and you remove the plaque and everything, and you provide a good environment around the tooth so that these tissues can heal. And they can adapt back to the tooth surface. Okay, now can you tell me what is the most common type of healing that we see in human body? Most common type of healing that we see in human body. Most common type of healing that we see within our body. Let's not talk about periodontium at all. Not inside the oral cavity. Anywhere in your body, what is the healing that you see? Healing is of two types. You can have either by repair or by regeneration. What do you commonly see in our human body? Either repair or regeneration. Okay, now you're all giving me the processes. Primary healing, secondary healing, formation of granulation. These are all the process by which these things occur. Yes, but the two things of two classification we can say of healing is by repair or by regeneration. Yes, Dr. Geeta, Dr. Shruti, you're right. Mostly the kind of healing that we see is repair. And in certain tissues, for example, liver, you will see regeneration. Epithelial skin or epithelial layer, you will see regeneration. Okay, now let's come to our periodontal tissue. Now, what did you all do? You did scaling and root planing. Okay, so now there is a wound there. When you removed all the subgingival calculus, plaque, everything, there is the wound is created there, and that wound has to heal. Now, can you tell me by which method commonly or after a conventional periodontal scaling and root planing, what is a common healing that you'll see? What is a common healing that you'll see? Is it repair or is it regeneration? Is it repair or is it regeneration? Again, you can give me your answer in the message box, chat box. So you are saying that if we just do a scaling and root planing in a patient that has had severe bone loss, it will have complete regeneration. It will have complete regeneration. No, it will not. The most common method by which our periodontal tissues heal, especially a pocket or this thing heals, is by repair. Okay, regeneration can occur in certain specific conditions. Okay, so most commonly it occurs by repair. Now we will see the definition of this both. What is regeneration? What is repair? So you will get a clear idea what is the difference between both. Now let's see the first thing, that is your periodontal regeneration. Let's see periodontal regeneration. Okay, let me just get my pen on. Yes, so periodontal regeneration. Periodontal regeneration is defined histologically. Please note this point. It is defined histologically. The only way you can confirm it, 100% confirmation, is wholly by histological basis. Okay, so periodontal regeneration is defined histologically as regeneration of tooth's supporting tissues. What are those supporting tissues? Alveolar bone, periodontal ligament, and cementum over a previously diseased root surface. So when regeneration is occurring, what is happening? All the structures, all the supporting structures are again reformed. New cementum forms on the root surface, new periodontal ligament and alveolar bone is formed. Okay, so that is regeneration. Now, what is repair? Repair is nothing but is the restoration of the new tissue that does not replicate the structure, does not replicate the structure and function of the lost tissue. And you can say it is just like a scar tissue forming, analogous to scar tissue formation. Okay, so that is a basic difference between periodontal regeneration and periodontal repair. Okay, so regeneration means every single structure is forming again, whereas repair, something is coming and filling up that wound, but it is not the same structure and it does not do the same function. That is periodontal repair. Okay, now we studied when we do normal kind of treatment, what we get repair. Mostly our body will end up repairing that site, especially at the periodontal site. It will end up repairing that. Very rarely, when the conditions are perfect, that you get periodontal regeneration. In cases of periodontitis patient, I'm talking about gingivitis, it is only within the gingiva, within the epithelium, it will regenerate. Epithelium will regenerate completely, so there is no problem. But when we are talking about the hard tissues like your cementum, your alveolar bone, then mostly the condition that we'll get or the outcome that we'll get is periodontal repair. Okay. Now, so what is the biological foundation of your periodontal wound? Biological foundation of your periodontal wound healing. Three things will occur. First, at that site, you will have inflammation. At that site. Then formation of a clot. And third one, formation of your connective tissue matrix, from which new cells will come and form structures there. Okay. Now, in a normal situation, like I said, in a conventional therapy, let me draw a tooth here. In a conventional therapy, okay, like this. When we have done done a treatment, let me just change the color. Okay, and this is your alveolar bone and this is your flap. When you put the flap back here like this, after the treatment, whatever treatment, or even you did a normal subgingival scaling, when the pocket epithelium attaches back to the tooth surface, what normally happens is there is inflammation first, then a clot is formed here, and then the cells from different areas will try to repopulate the site and form new tissues there. Okay, but when you have repair occurring, that is the most common outcome that you get. What happens? This epithelium grows down onto the root surface till where the base of the pocket was there, and it ends up forming as your long junctional epithelium. It forms as your long junctional epithelium. I will draw this picture here again so that you understand. Okay, this is your alveolar bone and this is your epithelium. So the epithelium, what it does, whichever pocket depth was there, it will just come and attach and protect the root surface. Okay, so this is what you call as long junctional epithelium. So there was a wound here, now the body is trying to compensate or cover that wound. And what is the most common outcome that we get is repair. And how that occurs? That occurs by formation of your long junctional epithelium. The epithelium grows fast onto the root surface, which was detached away from the epithelium, from the junctional epithelium and from your bone. What it does, it will form a barrier here. Why it is doing that? It is to prevent the root surface. Just like your hand, imagine you get a cut. What is the first healing process? The epithelium will form a layer on top of it and cover the wound. The same thing is happening here. The epithelium, that is your gingival epithelium or your oral epithelium, it grows fast downwards in an attempt to cover the wound area. And that results in the formation of your long junctional epithelium. Okay, now the second situation is when all these conditions, that is your inflammation, fibrin clot, and connective tissue matrix are ideal, and the epithelium is somehow not reaching that site first, and all the cells from the connective tissue matrix reach there, then you will get regeneration. That means you have to block out this epithelium. The epithelium should not come there first. Other than that, cells from your periodontal ligament should come there first for the wound to have regeneration. I hope that is clear. Okay, so now we know that for normally any wound will mostly undergo repair, but if you want regeneration to occur, you want some kind of barrier for the normal repair process to stop and the other cells to occupy the wound area so that you have regeneration. And based on this concept, the guided tissue regeneration technique was put forward. Now, what is this technique? Now, here you can see this is a tooth that is this tooth having gingivitis or periodontitis? Can you tell me? This is the bone. This is the bone here. Periodontal ligaments can be seen here and a pocket formation here. Okay, I'm not drawing here inside pocket form. Can you tell me, is this tooth showing gingivitis or periodontitis? Yes, it is showing periodontitis. It is showing because why are we saying periodontitis? There is loss of alveolar bone. You can see an angular pattern of bone loss. There is loss of periodontal ligament on this surface and even the cementum is destroyed. Okay, now if we do the basic process, scaling and root planing, what will happen after your scaling and root planing? This epithelium will cover like this. Is this clear? This epithelium will grow, like once we attach it, it will grow and it will form what? What will it form? This epithelium will grow onto the root surface, cover the wound area, and it will result in the formation of, what does this structure? Yes, I just talked now. It forms long junctional epithelium or epithelial adaptation. Okay, see this end of this epithelium will start growing and it will cover the root surface. So you will end up having repair of the tissue. You will end up having repair of the tissue. Okay, now that is your body's response. That is your body's response to have repair done in that area. Why? Because your body is trying to cover the root surface to protect it. That's your natural response. Now, do you want that? As in a patient where you feel that you can regenerate the tissue there, all other factors are ideal, angular pattern of bone loss, everything else is good, so you think that okay, this patient is ideal for regeneration, let's attempt it. Now what do you want? You don't want this to happen. You don't want this epithelium to grow down so fast. So what do? After you do all the scaling and root planing and cleaning of the wound site, you place a membrane. You place a membrane here. Now, what does this membrane do? This membrane, it blocks out this epithelium from growing down onto this root surface. Onto this root surface. So now there is a barrier here that is preventing the formation of your long junctional epithelium. The formation of long junctional epithelium is blocked by that membrane. So now you're guiding the remaining tissues. You're guiding the remaining tissues, that is cells from the periodontal ligament, from the bone, to occupy the wound site, and form the cells that is required to form new periodontal ligament, new cementum, and new alveolar bone, resulting in the formation of, or resulting in regeneration. Resulting in regeneration. Okay, that is the function of GTR. Is this clear? Till now, is it clear? What we talked about, is it clear? What is repair? What is regeneration? What is normally happening when you just do a scaling and root planing? And what do we do separate for regeneration to occur? For regeneration to occur. Is it clear? Okay, very good. So I hope till now it is clear. So now, if somebody asks you, what is the function? What is the function of GTR? You have an MCQ question. What is the function of GTR? Can you tell me what is the, let's write it down here. What is the function of GTR? Anybody? What does it act as? What does it act as? What does GTR act as? What is the terminology that we'll use? It acts as a barrier. It acts as a barrier. Yes, it acts as a guide for the remaining cells to form. But first, it acts as a barrier for what? For your epithelium not to grow down. Okay, so see, it's blocked here. It's blocked your epithelium from growing down. So it is a barrier. It is a barrier. What else it is doing? What else is it is doing? What else it is? Can you see this, the wound here? Now the wound that you have curated out, cleaned out nicely, everything is cleaned out, and there is just the blood there, the clot that has formed after healing, and all your tissue space or that wound space. Yes, prevent long junctional epithelium, it's correct. That forms a that comes under barrier. That comes under barrier. The second thing it does, it whatever clot is formed inside, we studied that three major things for healing. One is inflammation. Second one is fibrin clot formation. Now this whole area is filled with your clot blood. Once you do all the scaling and root planing and remove the granulation tissue, what happens to the wound? If you get a cut in your hand, what happens to your wound? It immediately gets filled with blood. So that fibrin clot is very important because that forms again a basis for your new tissues to form. So what it does, it clot stabilization. Clot stabilization. It stabilizes the clot, which is very important because we studied that fibrin clot is very important for healing. So this clot here within that wound area, it is stabilized because from top the GTR is sitting and it is protecting the wound. Third thing, third important thing, whatever space is there in this area, if it was long junctional epithelium, what will happen? The epithelium will grow into that space and that space will be obliterated and nothing else will be able to grow in there. So what is it doing? It is doing space maintenance. The space is maintained. The space is maintained. Space is maintained. So it does space maintenance. Okay, so these are the three important functions of GTR. What are it doing? It is causing a barrier. It is causing a block. Second one, clot stabilization. It is stabilizing the clot within the wound, which is very important for regeneration to occur. And third one, it is maintaining that space like that so that new cells, whatever required cells, can come there and form these new tissues for regeneration. I hope this is clear. What junctional epithelium, what GTR does, what is its function, what all it does. It acts as a barrier, it does clot stabilization, and it does space maintenance. Okay, now moving on. So now we studied all these things. Now I kept on telling that the ideal cells have to come there. The ideal cells has to come there. What are these ideal cells? I just got a message. Yes, I'm coming there. Prakruti. I'm just coming there. So we are gonna tell. Till now, I said that new cells are gonna come there. New cells are. Where are these cells gonna come from? Which are the cells that we want to come there? Okay, so we are gonna talk about this. Now, this concept of new cells coming and occupying this was put forward by a famous scientist. An MCQ question for you guys is Melcher. Okay, so Melcher is the person who came up with the concept of compartmentalization. Compartmentalization. He said that different cells will try to occupy the wound area. Once you have a periodontal lesion and once you try to treat it, that treated wound site will be occupied by different cells. But only one group of cells or a certain group of cells is ideal for regeneration. If not, it will cause something else. If not, it will cause something else. So now we are going to see which cells we want in that region. The first cell he talked about is your epithelial cells. This one is your epithelial cells. Now we already studied epithelial cells are the fast growing cells, and if they occupy the wound site fast, what does it result in? What does it result in? If the epithelial cells jump and come to the wound site first, what will it result in? Yes, all of you have to answer. So that it's a repair by formation of long junctional epithelium. Repair by. So look at what has happened here. The wound site got filled with, I'm sorry, let me just go back to my pen. The wound site got filled with long junctional epithelium. See, got filled with long junction. So is this ideal? Is this, let me put it in this way, is it ideal for regeneration? No, it is not ideal for regeneration. But is it a good thing that is happening? Is long junctional epithelium formation good or bad? Let me put it like this, a question. Is long junctional epithelium formation good or bad? Let's not put regeneration into concept here. Just the formation of long junctional epithelium. Is it good or bad for your body? Yes, very good, Prakriti. It is good because it is a method by which your body is trying to protect the wound. But is it a stable method or is it a stable process? No, because it's just an epithelium forming onto the root surface and just adapting to it. Any inflammation, it will open up, lead to the formation of new pocket. So it's a temporary measure by your body to prevent root resorption. Okay, that is why your body emphasizes on having long junctional epithelium there. So for regeneration, for the concept of regeneration, it is bad. We don't want the epithelium to grow there. So the first thing we studied is your epithelium, which will result in formation of long junctional epithelium, and it is not ideal for regeneration. Now, the second tissue that can occupy the wound area is your connective tissue of the epithelium. Connective tissue of your epithelium. Okay, the connective tissue of the epithelium can grow into the wound site, and what it will do, it will adhere onto the root surface and it will cause root resorption. Is it ideal? If gingival connective tissue grows onto the root surface, resulting in root resorption? Is it ideal? Yes or no? Just put yes or no. Very good. It is bad for us. We don't want any root resorption. We are looking for new cemental formation there. So that is also bad. Now, the third one, if only your bone cells come there, only your bone cells reach there, what will happen? Again, it will result in root resorption and ankylosis. So if only your bone cells reach there, it will result in root resorption and ankylosis. So is it good or bad? Is it good or bad? Is it good or bad? It is again bad. So we don't want this also to happen. We don't want this also to happen. So now what is the only cell that is left behind? That is your periodontal ligament cells. Cells from your periodontal ligament area. Cells from your periodontal ligament. Periodontal ligament cells. Pen is giving me trouble today. Okay, periodontal ligament cells. Okay, so these cells is ideal. Now, what do these cells do? The periodontal ligament cells, along with your alveolar bone cells, if they combine together and they work, they will result in formation of new attachment. That is new cementum, new alveolar bone, and new periodontal ligament fibers. Can you see now here, the bone level has increased. New fibers have been formed. It was not formed here. It was not formed here. It was not formed here. The only area where it was there was when your periodontal ligament cells occupied the wound. When your periodontal ligament. So this is we give a 3-star to this. We give a 3-star to this. Why? Because that is what we want in the wound site. Is it clear now? Which cells should occupy that area? Which cell should occupy that area? It is your periodontal ligament cells. It is your periodontal ligament cells. Is this clear till now? Till now, yes, very good. So in regeneration, let me put it in simple way. In regeneration, for a wound, for a periodontal wound, for a periodontal wound to heal, okay, like this. Let me draw it like this. This is your bone, alveolar bone. Let me just change the color. And this is your gingiva. Okay, now if you want new tissue or you want regeneration to occur, only process to make them work together is the only process for the periodontal ligament cells to come there is by blocking the epithelium and your gingival connective tissue, because these two grow very fast and occupy the wound. That is your body's response. Your normal natural response is your epithelium to grow into any wound site and cover it. So that is why we are using GTR, and that is why we are using GTR. Okay, let me show you now what. Let's put everything together now. So now this is imagine I have opened a flap, curated everything out, and I am placing my membrane here like this. Placing the membrane here. This is my GTR membrane here. Okay. This is my GTR membrane here. Okay. Now when you do any kind of periodontal regenerative surgery, normally you place bone grafts. You place bone grafts for the bone to form there. You place bone graft, which is normally along with certain growth factors. So you add growth factors. That all we'll study. Okay, that all we'll study later. Okay, we'll add certain growth factors also, whatever we can get. And then you have placed the GTR here. Now what happens? This epithelium, it is blocked here. So this long junctional epithelium cannot grow down. Can your connective tissue in this area, can it come to the wound site? No. So now this GTR, what has it done? It has acted as a barrier. It has acted as a barrier. It has allowed the bone, whatever graft that you have placed along with the blood, to form a good, solid, stable clot. And it has provided the space for the cells from your periodontal ligament cells to come and occupy, so that new bone is formed, new cementum is formed, and new periodontal ligament is formed. So after months of healing, you will end up having something like this: a new bone formed, more height, gain in attachment height, new periodontal ligament fibers, and even new cementum formation. Okay, so that is the role of guided tissue regeneration, or your GTR membranes. Okay, I hope it is clear now. Now we have put everything, all the concepts together, we have put it into this single diagram. Is it clear? GTR. So if you get any questions from this, after this lecture, you should not have any doubts about at least the concepts. The concepts of GTR should be crystal clear. Can I get a yes if it is clear so that we can move on? 3 or 4 more slides left. Okay, very good. Okay, excellent, excellent. Okay, so now we will move on. Okay. Now, can we do guided tissue regeneration in every single patient, in every single defect? No. There are certain indications and there are certain contraindications for this. Okay, now let's see what are those. What are the indications? The defect should be at least a 2 or 3 wall defect. We'll study what are intra-bony defect, what are supra-bony, everything we'll study. For time being, just know that it's done in mostly in intra-bony defects. It can be done in circumferential defects, class 2 molar furcations, and in certain recession defects. So these are the indications where you can use a GTR. You cannot go and use a GTR in every site expecting regeneration to occur. No, it will not. Okay, so there are certain cases that you should select before you go ahead and do these things. Okay, and there are a lot of contraindication, more than indications. Now you see there are a lot of contra. So you should screen your case as a periodontist. You should screen your case, see what are the features that are ideal for that patient to carry on with this regenerative procedure. Understand this, regenerative procedure is just not GTR. Okay, you have bone grafts coming into that area, you have this membrane playing a role, you have certain root biomodification agents, you have certain growth factors included. All of this combined together, you get a regenerative therapy. Okay, we'll study about periodontal regeneration separately, but just to give you an idea, it's just not GTR. Okay, there are many factors which play a role in complete regeneration. Okay, so these are the indications and these are the contraindications. Not going into the details of contraindications, but these are the different ones that you should be aware of before you select a case for regenerative procedures or even placement of a GTR membrane. Okay, now to give you a brief idea about the GTR membrane. The GTR membrane can be classified into 3 categories or into 3 classifications or generations. You have first generation GTR. You have first generation. What are these? These are certain membranes that you place, but they are non-absorbable or they do not resorb out. Okay, so what is the disadvantage of this membrane? What is the disadvantage of using first generation GTR membranes? What is a disadvantage of first generation? That do not resorb out. Okay, so you do all these. Yes, very good, Prakriti. Excellent. See, you place this membrane and you close the wound, everything, and you expect the bone to form, a new periodontal ligament, everything to form. But the problem is the patient will have to undergo a second surgery. Why? You cannot leave that membrane inside like that because it is not resorbable. So you need a second re-entry into that surgical site. Is it ideal for a patient? Is it patient compliant? Patient already did a lengthy surgery with grafting and membrane and all those things, and then you are telling the patient after 4 to 6 weeks you have to come back to do another surgery to remove this. Will they be happy? No, they will not be happy. So this was a drawback of your first generation GTR, and because of that they introduced the second generation GTR, which was absorbable membranes. Can you give me a simple example of a second generation GTR membrane which you commonly use in your surgery, in your clinics? Not as a GTR, but you would have used it in many other ways. Anybody? Mostly when after you do extractions, you end up, no, not periochip. You're using periochip in your surgery. PRF, no. PRF, okay. It is not a membrane per se. I said after you normally do extraction, if the site is bleeding a lot, you use this membrane there. You use this substance there to fill into that socket so that the bleeding doesn't occur. What is a common thing that you use to prevent bleeding? Anybody? Have you heard Surgicel? Collagen membranes? Surgicel? Nobody has used Surgicel till now? Yes, very good, Dr. Geeta. Yes, Surgicel. So these are collagen containing membranes that are absorbable in nature. Okay, so for GTR, they are modified in a different way so that they can be fitted into the wound site. Okay, So that is the second generation, that is absorbable membrane. So after certain period of time, it resorbs out on its own. So you do not need the second surgery. And then the third generation, after the first generation, they introduced the second. From the second, they introduced the third generation. What did they do? They incorporated, they said, okay, anyway, you're putting the membrane there in the wound site. Why not we add certain factors which will help in regeneration? Let's infuse some growth factors into it. Let's infuse some antibiotics into it. Let's infuse some adhesion factors into it so that it will form a good membrane, or it provides many other advantages. And that is how the third generation GTR membranes were introduced. Okay, so they have growth factors, antibiotics, and adhesion factors. Okay, we will study the detailed of each generations, what are the examples and everything in our classes. Okay, what is the first membrane that was introduced? MCQ question. Which is the gold standard of GTR? Again, MCQ question. All of these things we'll study in our class. Okay, this is just to give you an idea. If somebody asks you, okay, you attended a membrane lecture, can you tell me how many generations are there? What is the difference between first, second, and third? At least you should be able to answer it now. Okay, I hope that is clear about GTR membranes. So with that, we come to the end of our lecture. And now I will show you some clinical pictures where the membranes and the graft combination was used for periodontal regeneration. Okay, periodontal regeneration. We are trying to regenerate. So this is a INFRABONY defect, distal to 4-7. So this is your 4-7. Here you can see a vertical defect here. And once the flap was opened up, you can see this big defect, distal to distobuccal. It's like a circumferential defect. Circumferential defect from one surface to other surface. That's what you call a circumferential defect. So now what you do, once you found out the defect, you open it up. There will be a lot of debris on the root surface. So you will do root planing. All the granulation tissue is removed out, and then you fill the site with bone. Can you see these things? What is filled here is all bone. Bone granules have been filled into that site. Now, if you just place the epithelium on top of it, what will happen? What will happen? If I just take a flap and place the epithelium on top of that grafted tooth, what will happen? Anybody? Anybody can tell me what will happen instead of now after this step? Okay. So now your concept is correct. Excellent. Okay, your concept is correct. But now comes that intricate knowledges. Okay. Now the bone graft, what did they do? They occupied that space completely. They occupied that space. The whole wound area is completely occupied by the now the bone graft. You've packed it with the bone graft, and if you are placing the graft, your flap on top of it, two things can happen. Two things. Either one, the graft is not taken up properly. Why? Because your epithelium has grown out faster than your bone growth, that it will result in, like all you said, long junctional epithelium formation. Sometimes this graft, along with the blood clot, will form a strong fibrin clot. It will form a strong fibrin clot, and what it does, it can act as a barrier. It can act as a barrier and prevent the formation of your long junctional epithelium. Okay, I'll draw and tell you what I just explained. So this is the defect like this. And you're going to place the graft inside it. Okay, let me put the graft in blue. So now this graft, along with the clot, it can sometimes, yes. Somebody can the graft? Yes, ideally it can, but always clinically not always necessary that it should. That is why you always place a membrane also. But it is not ideal that every case you can go ahead and place the membrane. I'm just giving you the concept behind it. Okay, so this is the graft placed here. And now I'm going to draw the epithelium that is going to come. Okay, let us put a different color to that. Let's put yellow to it. Okay, now I place my epithelium on top of like this. Two outcomes can come. What is that? The first one, the epithelium can outgrow the graft and form long junctional epithelium. So now, is there any use of the graft that we placed? Is there any use of the graft that we placed? Yes or no? If the long junctional epithelium, once the long junctional epithelium has grown in, is there any use of the graft? What is the graft going to go do? No, it is gonna get resorbed out. It is gonna get resorbed out. Maybe minimal uptake or something, but no significant changes you will see. The second outcome that you can have is where the graft along with that clot, blocks this epithelium from growing down. Not always possible, but it can happen like that. Blocks the epithelium from growing down, and this graft can be taken up. Okay, and this graft can be taken up, and you can have gain in clinical attachment level. You can have some amount of bone growth in it. I hope this is clear. This concept. So basically, all you want is a barrier, a good fibrin clot at the wound site so that the epithelium doesn't come down. I hope that is clear. Okay, so in this case, they have placed the graft here, and then what have they done? Can you see this white membrane placed around it? White membrane placed like this from this graft area to here. That is your GTR membrane. And then the flap is sutured. One important thing you should understand is that when you place a GTR membrane, you should get a primary closure. Otherwise, this membrane will get infected. If it is exposed to the oral cavity, the membrane get infected and it can be rejected. Okay, so primary closure. Can you see? It's well approximated. Nothing can be seen outside. Proper closure of the wound. Okay, so that is the and this is the outcome that you can see here on the OPG. Oh, sorry, on the IOP. Okay, see, can you see this radio density, that opaqueness, radio opaqueness in this area as compared to this area here? You can see that increased radio opacity in that region. See, here it's more radiolucent, whereas here when you come, it is more radio opaque. That means some bone has filled into that site. Some tissue has regenerated into that site. Okay, now, can I ask you something? Can you 100% verify that regeneration has occurred in this site? Can you say 100% that regeneration has occurred seeing this radiograph? No. Very good. An MCQ question. You can never say that. Okay. How can you confirm 100% that it is regeneration that has occurred? Which is the only method by which you can say there is 100% regeneration? Which is the method by which we can confirm and say, okay, re-entry, Dr. Geeta, is good. You can reconfirm bone formation. If it is guided bone regeneration, you can reconfirm. How do you reconfirm cemental formation and PDL formation? Can you reconfirm that if you do a re-entry? No pocket, no, you cannot confirm that. No pocket can appear even with long junctional epithelium. If long junctional epithelium is adherent, is adapted well, it will also stop the pocket formation. I explained in my first slide, which is the only method by which you can confirm 100% whether a regeneration has occurred or not. Bone formation, you can only see by X-rays. And like somebody said, a re-entry. You can check, okay, open up the flap, okay, bone has formed in that defect. The only way you can say is by histological analysis. Very good. By histological analysis. Can we do that in humans? Can we do histological analysis in humans? Cut a section, put it under microscope and see. Cut a section, put it under microscope and see. No, it is not possible. Okay, so that is why this is a gray area. Okay, this is a gray area. You can do on animals and then test them. Do the histology after lab animals, you can do it in them. Many studies have been done and there are positive results. But in humans, that is the drawback we have. We cannot histologically confirm it. Okay, so I hope that is also clear for you guys. Okay, moving on to the next slide. Again, this is a class 2 furcation management. Okay, see, here you can see the furcation involvement, class 2 with a horizontal component of bone loss. What is this that has been placed here? Can you see small granules that has been placed inside that defect after the root has been cleaned and everything? What is that? That white dots that you see. Anybody? Those are your, what are those things? That white dots that you see. That's your bone grafts. Okay. It's your bone grafts. So it is packed with your bone graft. And now can you see the GTR membrane? See, that site is packed with the GTR membrane covering the graft and the up to the root surface. Around 2 to 3 mm below the gingival cemental enamel junction, we place the GTR membrane. Okay, the measurements and all, the surgical part we'll study in detail when we do GTR in our classes. Okay, so this is how you place it, and then you close the site. And again, see here, you can only analyze either by, you can analyze only by IOPA or by clinical diagnosis, by probing pocket depth. Pocket depth you can check for CAL. If there is gain in CAL and decrease in pocket depth, that means okay, some kind of regeneration has occurred. The tissue has, some kind of tissue has formed there. It can be bone, it can be cementum, we don't know, but we are happy that the patient's pocket depth, see here, the whole probe was going inside, here only just a little bit is going inside. With this you can say okay, there is some kind of regeneration, the patient has had, the site is healed. Okay. Okay, so that is another example of a class 2 furcation where you can use GTR membrane. So this is just to give you an idea how we place it and how we use it in different cases. Okay, now before you leave, there are certain important concepts that you should take with you today. Okay, what are those concepts? GTR is not a procedure for treatment of periodontitis. First thing you should understand. If somebody asks you, all of the following are treatments of periodontitis, and they put scaling, root planing, excess flap surgery, and then they put GTR right there. GTR and bone graft. No, they are not. You are not treating periodontitis with GTR. Periodontitis was treated by removing all the, what do you say, plaque and calculus and all whatever granulation tissue, all that you removed. You made it stable. But in certain cases, like we said, certain indicated cases, you have defects and you feel that you can regenerate it. That regeneration is brought about by GTR. Okay, so GTR is not a procedure for treatment for periodontitis, but rather a technique for regenerating defects which was developed as a result of periodontitis. Okay, so it is something you are trying to treat which was caused by periodontitis. Okay, regeneration is biologically possible but can be verified only by histological analysis. Another drawback that we have, so that we cannot 100% confirm and say, okay, this technique is excellent. No, this technique is, we can't say that. We can say that, yes, we are having gain of clinical attachment level. The patient is much better. There's no pocket depth. There is bone growth after seeing the IOPA, we can say. But we cannot say verify it. It can be only done by histological analysis. Why regeneration is not 100%? See, again, what is Fatima? What is the definition of regeneration? If we are talking about periodontal regeneration, it means formation of new cementum, new alveolar bone, and new periodontal ligament fibers. Can you see all these can you see PDL in IOPA? You cannot. Can you appreciate cemental growth in IOPA? You cannot. Okay, that is why I said if it is bone regeneration, yes, there is a procedure known as guided bone regeneration, what we do for implants, that we can confirm by IOPA. Okay, the bone has reformed here. Bone formation, yes, you can confirm. Regeneration of periodontal tissues, no, you cannot confirm it by IOPA. That IOPA will only help you in bone confirmation. Is that clear, Fatima? I hope your doubt is clear now. X-rays will only show bone. You cannot identify cementum and PDL from that. Very good. Okay. Moving on. Epithelial migration and formation of long junctional epithelium is the fundamental healing process and prevents root process. See, I said long junctional epithelium formation is actually good for us, but it is not good for regeneration. It is not good for a long-term prognosis of the patient. No, it is not ideal, because at some point, even a little bit of inflammation, it will open up, leading to new pocket formation. So it is a fundamental healing process of our body to prevent root resorption. And last one is your definition for regeneration. I just repeated it, gonna repeat it again. Formation of new cementum, new alveolar bone, and new periodontal ligament, which is the most important points. New cementum, new periodontal ligament, and new alveolar bone. which can happen only when prevention of junctional epithelium. Downgrowth of, you block the downgrowth of your junctional epithelium and your epithelial connective tissue. You don't want these structures to come there. You don't want these structures to come there. You want cells from your pedial space to occupy the wound and lead or start formation of osteoblast, cementoblast, and cells from the for the periodontal ligament fibers. Okay, I hope it is clear. Now we have few questions based on this same topics that I've discussed. We will just discuss. You can put your answer in the key and then we can discuss fast. Okay. One of the techniques with the most successful documentation of regeneration is. So they are asking a technique which helps you for regeneration. Yes, very good. It is your GTR. Ostectomy is a resective procedure. You are removing bone from the bad. Root modification, biomodification, let give you an idea itself. It is part of your regenerative procedure, but it does not give any added benefit. Okay, you can do it, you cannot do it, but it does not give you any added benefit. Okay, so there are, let me say it now itself, there are only two techniques that has been documented to have the most successful periodontal regeneration. That is GTR and bone grafts. Okay, these two have been the most commonly associated with most successful documentation of periodontal regeneration. Question number 1, answer is GTR, B. Okay, question number 2, restoration of lost periodontium or supporting tissue includes formation of new alveolar bone, new cementum, and new periodontal ligament. What is it? Reattachment, epithelial adaptation, regeneration, repair. Yes, very good. It is regeneration. See, new alveolar bone, new cementum, new periodontal ligament. Very good. Question number 3. The concept of compartmentalization, in which the connective tissues of the periodontium are divided into 4 compartments, was developed by. Yes, very good. It was developed by Melcher. The concept was developed by Melcher. Based on this concept, we started developing your GTR. Based on this concept, he started developing GTR. Okay. Question number 4. Long junctional epithelium formation results due to migration of oral epithelium, gingival connective tissue, alveolar bone, PDL. Should not make a mistake in this. Multiple times I kept, yes, very good. It is your oral epithelium. Long junctional epithelium results due to migration of your oral epithelium. I drew that diagram multiple times. Okay, let me draw it again so that you don't forget this. This is very important. An MCQ question that keeps repeating itself. This is the epithelium. When you place the epithelium, what it does, wherever till the base of the pocket, it forms long junctional epithelium. It just adapts onto the root surface. Oral epithelium. Okay. So question number 4, answer is A, oral epithelium. And our last question for today. It's a lengthy question. All are true except A. During wound healing in periodontium, fibrin linkage being disrupted results in long junctional epithelial type of attachment. Role of GTR include epithelial exclusion, cell tissue repopulation control, space maintenance, clot stabilization. Second generation GTR requires shorter waiting period for removal of membrane as compared to first generation. The number of bony walls and depth of the intra-bony components are critical for positive GTR results. What is the answer? All are true. Please read the question carefully. All are true except. Yes, all of you are writing C. Can you tell me what is wrong in that? What is wrong in that sentence? What is wrong in that sentence? What was wrong in that? Yes, very good. It is an absorbable membrane. So it does not require a second surgery to remove the membrane. It does not. They have written shorter waiting period. There is no need of a re-entry. It resorbs out on its own. Excellent, guys. Very good. So all of you got all the 5 questions correct. Okay. Okay. So with that, we come to the end of our session. I hope you got today's aim was to give you a general idea of GTR membrane. Okay. Normally when we study each topic in detail. Today is just a brief overview of all things, just to give you an idea how we go about in our classes. Okay. So thank you so much for your patient listening. See you all for our crash batch course. Thank you all. Bye-bye.
Okay, thank you so much, Dr. Jerry. It was a wonderful session. So hope that you had a really great time with the periodontics by Dr. Jerry. He is one of the most enthusiastic faculty at Focus, and we are, happy to have him around. So
Thank you.
hope to see you guys again in the next session. So good night, everyone. Be ready with your all notes and everything for the next session. Okay. Good night.
Good night. Good night.